I was chairing a session on the earlier diagnosis of cancer, in particular talking about how molecular tests can be used, because there's a whole new genomic era that we're in. So can we have a new generation really of molecular tests for earlier diagnosis of cancer? And I was talking specifically about esophageal cancer, adenocarcinoma, which is a cancer with a very poor outcome. And I think we could make a real impact if we could find a way of diagnosing it earlier. At the moment, the current options are endoscopy and biopsy. The main risk factor for this kind of cancer is heartburn, reflux symptoms. The people most at risk, particularly white men over the age of 50. Obesity may play a role, partly because you get more reflux. So that's a lot of, a big proportion of society would fulfil that sort of risk bracket. So the problem is that you can't really endoscope everyone with reflux symptoms, and GPs have a very hard task. 10% of GP consultations are around heartburn symptoms. So, who do they refer for endoscopy? And the corollary of this is that as endoscopists in hospitals, 70% of the endoscopies we do are normal. So, that's a big burden on healthcare. It's a fairly invasive test. So what I've been interested in for some time is how we really come up with a new paradigm for diagnosis. So trying to find something simple, more cost-effective, GP-based, and to couple a different cell collection device with a molecular test that could be objective, accurate, and do two things really with a molecular test, both diagnose Barrett's and risk stratify, because you don't want everyone with Barrett's to have an endoscopy, because then you get back to the same sort of a problem. So that's really what I was presenting, an update on our work in this area. So the cell collection device is called the cytosponge. So this is in the primary care setting. The patient comes to see the GP with some heartburn symptoms. They swallow this pill on a string, about the size of a multivitamin pill. It wiggles down to the top of the stomach. Just with the warmth of the stomach, it'll dissolve, and out pops a spherical sponge. And the nurse pulls that back just a few minutes later and collects about 500,000 plus cells on this sponge. That just gets put in a standard preservative pot and sent to the lab. So from the patient's point of view, I think this is a pretty straightforward, simple test. It will make their eyes water a bit, but it's really not bad. Compared with an endoscopy, it's a lot easier. It's a lot more cost effective. And then the lab side of it, you can be much more sophisticated. You want it easy for the patient, but to really be sophisticated in terms of the molecular tools that one uses. So the first test that we've done quite a lot of work now on and tested over 2,000 patients in 2 studies is to diagnose Barrett's, and that's using one specific biomarker called trephor factor 3. It's a nice simple test. It's an immuno-based test. So, standard clinical path labs are used to doing immuno-based tests, and it's scored simply positive or negative. So even if you just have one cell that stains with this antibody, it's positive. And then what we're working on now, and I presented some new data on this today, is how you then, with the same sample, if it was TFF3 positive, so you think the patient's got Barrett's, how you then check whether they're high risk or low risk. And so we're still refining this, but it seems that P53 is a critical gatekeeper mutation for patients that go on to get cancer. And you can test for P53 overexpression with an immunomarker. And you can also test for mutations on the cells from the cytosponge, all from the same sample. So we're using that. We've done some work to see what's the best combination of biomarkers. P53 on its own may not be enough, but the pathologist's diagnosis in terms of whether the cells look atypical is actually also very predictive. And how long the Barrett segment is that the patient has, if you know that information. So using all those 3 things together, we think we can then put patients actually into 3 buckets. A high-risk group, and they would go straight to endoscopy and have treatment if it's confirmed. A intermediate risk group where we would say repeat the cytosponge in about 6 months. And a low-risk group where we feel pretty laid back. They've got Barrett's, we think it's low risk. Swallow the cytosponge again in 3 years' time. So we're still confirming exactly how we want this risk stratification to be done, but that's the kind of way we're thinking about it at the moment. It's a completely new area. So people for a long time have been thinking at endoscopy, what else can you do on the biopsies to risk stratify? One of the big problems with biopsy is sampling bias. So Barrett's is a polyclonal disease. So, you can miss the spot that you want with a biopsy. And typically at surveillance and endoscopy, we do 4 biopsies every 2 centimetres. And even then, we know that we sometimes miss the area. The great thing about the cytosponge is you get a nice sweep of the whole esophagus. So there's less sampling bias. And currently, the biopsies are just looked at by pathologists for dysplasia. No molecular biomarkers are typically used. People are starting to use p53 immunohistochemistry. That's the first one that's now got into our British Society guidelines. Worldwide, that's still not used, really. People have been looking at adding molecular tests to biopsies for quite a long time, but haven't really come up with something which is clinically applicable and accurate enough. So I think this, again, the cell collection, I think, is really a pivotal part of this to get that, much less sampling bias. And because the cell collection is so good, then I think we can do clever things with biomarkers. Plus, the technology's really leapt ahead. So it's much easier to look for mutations now in a sample than it was before. It's about 1 patient in 300 per year. So it's a low absolute risk. So that's why I think it's really important that the test is simple, inexpensive, and that you have the risk stratification. So you don't want everyone, at the moment, everyone with Barrett's goes through repeated endoscopy every couple of years. That's quite a big burden when most of them will never get cancer. So if you can take it away from that, as much of the effort is on identifying the high-risk people as is in reassuring the people actually at very low risk, so that you can give them good reassurance that's really, you're confident that they really are low risk, and then let them off the hook, so they don't have to have repeated testing. That's the hope. So the idea is we'll do more case finding and then concentrate more on the high-risk people. I mean, healthy lifestyle is certainly important, and I think our understanding of diet and cancer is actually pretty primitive. We don't really understand much about it. It's hard to study. But no doubt, obesity is a big problem in the Western world. And obesity, of course, is a risk factor for all sorts of things. But obesity is one of the risk factors for this kind of cancer. And so, absolutely, it has to be sensible to be getting people to be healthier in the first place, rather than then just trying to, catch the problem once it's already developed. You would hope so, wouldn't you? Lifestyle factors are important to help reduce reflux. And if you look at the kind of nice stepwise guidelines that doctors should give their patients, that is part of it. It's quite hard to do. GPs are pressed for time, and I think we could all do a lot more of that. So I think as part of this, if you're going to introduce more systematic testing in the GP surgery, then absolutely we should be talking to patients more about risk factors.